Treatable, can I start?
Yes, sir.
Yeah, thank you, Chitrikala. Dr. Mutada sir and Dr. Shama Sultana, with your permission, shall I start?
Yeah, sure. Go ahead.
Yeah, thank you, sir.
Yeah.
Good afternoon, doctors. This is Dr. Someshwar from Shield Healthcare. I hope
Treatable, can I start?
doing well. Yeah.
Yes, sir.
Yeah, thank you, Chitrikala. Dr.
Sorry. Chitrikala, can you please share the screen? Yeah. Sorry, everyone. Yeah. Good afternoon, everyone. This is Dr. Someshwar from Shield Healthcare. And as we know that from February 7th to 14th is observed as an International Congenital Heart Defect Awareness Week. So in celebrating this, NARI'S Healthcare along with Shield Healthcare is giving a live webinar on tender heart care and time to stand for it. So now with this occasion, let me introduce our master of the ceremony, Dr. Shama Sultana ma'am. Can I see the CV, please? Yeah. She is a young, enthusiastic, and cheerful ops and gynecologist, as well as an infertility consultant. And she is the chairman and co-founder of the Hope Win Hospital, and also working as a gynae consultant at Star Hospital, Guntur. She did her PG diploma in assisted reproductive techniques from the KL, Germany, and training in basic ultrasound and endoscopy from Foxy. And she also done her diploma in aesthetic gynecology, and she had colposcopy expert training from Delhi Gynec Forum. And she has been a speaker at Femicide in Community Connect program on prevention of women's health care held in May 2021. She is a public awareness in charge in sexual medicine committee Foxy and editor-in-chief for Dr. Parag Patil's Awareness E-Digest. And she has also served as a faculty and moderator for Open Forum Awareness on Adults and Sexual Health and organized by the POGS in June 2021. And also she is a founder of NARI'S Healthcare organization in Guntur for adults and young women health awareness mission. So with this, we welcome you, ma'am. And let me hand over the session to Shama Sultana, ma'am, for the further proceedings. Over to you, ma'am.
Yes, thank you. Please play the YNHC video. Thank you.
NARI'S Healthcare. Who is Nari? She is adolescent girl and women who are the future of nation. They are in a journey to pursue their dreams. They need courage, determination, dedication, focus, and most important, health. They are surrounded by number of health problems. So here is our NARI'S Healthcare founded by Dr. Shama Sultana, which shall provide awareness by online webinars, health-related videos, offline high school and college health camps, and many more. Our goal is to reach nationwide in 10 years. We need everyone's support. Thank you.
So thank you. So hello and good afternoon. I'm Dr. Shama Sultana, founder of YNHC, and I welcome all to this webinar. As we have already seen the intro video of YNHC, we have mentioned that NARI'S Healthcare Organization shall have online and offline awareness programs, workshops, and medical camps. And today, on the occasion of Congenital Heart Defect Awareness Week, which is observed from February 7th to 14th, we are taking this privilege and we are here to promote awareness and education about congenital heart defects. It is annual campaign to honor and remember everyone who born with a heart defect, and the medical professionals who care for those born with the heart defects are recognized on this day as are the experts who are involved in conducting research for treating and preventing heart defects. So I'm glad to introduce our eminent speaker who have approached us with his research by himself to give YNHC an opportunity to showcase his special lecture through our YNHC platform. He is none other than Dr. Murtaza Kamal sir, consultant pediatric cardiologist from Ramesh Hospitals, with the topic of tender heart case, time to stand for it. Please, can I have his CV, please? So this is his CV. Sir is a MD Peds and DNB Peds, DR and B pediatric cardiology. He's a consultant pediatric cardiology. He did his MBPS at VMMC and Safdarjung Hospital, New Delhi, and MD Peds at VMMC and Safdarjung Hospital, New Delhi. Then DNB Peds from National Board of Examinations, New Delhi, and DRNB pediatric cardiology from Star Hospitals, Hyderabad. So his areas of expertise or acyanotic congenital heart diseases, transcatheter percutaneous advised closure of ASD, VSD, and PDA, neonatal cardiac interventions for structural heart diseases, then fetal cardiac imaging. He is having already awards and recognition. He was awarded second prize in award paper presentation in CSI Telangana 2021 Hyderabad for paper titled Tissue Doppler, Strain Imaging and Conventional Two-Dimensional.
I think Dr. Sharma Sultana, it's like too much for me. It's okay.
Yeah, you are so great. So you have already with such an awards and recognition.
Really my privilege to share the platform with Yuvanari, because really I'm privileged to be associated with you people so that awareness can be reached in every aspect of into all the society parts of the country. And it's like Yuvanari is not only confined to the young women, it should like expand its wings in other things also, like in pediatric part and all. That's why she has accepted my proposal of engaging this congenital heart disease with her. I'm really grateful and thankful for her. Like she's able to balance both her clinical and social awareness work. That's really appreciable. Thanks a lot, Dr. Shama Sultana, for the nice introduction, kind introduction. And thanks a lot, Dr. Someshwar and Shield Connect for giving me this platform to be associated once again with you. Without wasting much time, I'll go ahead with my short presentation, which is basically to create awareness of congenital heart disease among different aspects, not only among people, but also among our doctors. Like which is very much in need. I think my slide is visible to all.
Yes, sir.
Yeah. So basically congenital heart disease are those diseases which are in the just a second, I'm having some difficulty here. Yeah. So basically, tender heart care, trying to stand for it. Like congenital heart diseases are those diseases which are present in from the birth in the babies, which are born with these diseases. It's not that heart diseases like general conception among people. General public is that heart diseases are a thing of adults only. So for the awareness of everyone, it's like these diseases can be there in kids also, and they are born with certain diseases which are in the heart. And it's really a high time for us to understand it clearly in all aspects. Every year around, like it is the most common congenital birth defect, congenital heart disease, and approximately 1 in 100 babies are born with congenital heart disease, basically. And this week of February 7th to 14th is celebrated as a Congenital Heart Defect Awareness Week. And this month itself is the Congenital Heart Disease Month, February. We know that our country, India, I'll be mainly talking about our aspects because we are very much different from the Western parts. Our country is the second most populous country, and it is among the fastest major growing economies. Like we can say, even like Shark Tank, India has already started. We are like among the fastest growing economies. So approximately 2.5 million kids are born per year worldwide, and out of which 2.5 lakh kids are born in our country with congenital heart disease. And these congenital heart disease, why is it important for us to take into consideration is that it is the most common congenital birth defect. It comprises of almost 1/3 of all the congenital birth defects. This is congenital heart disease. And if we look into the birth prevalence, it's around 1 in 100, that is 10 per 1,000 live births. But our scenario is quite different from the Western world. It is seen that in Asia, there is a high birth prevalence overall, and there is a high degree of consanguinity also. And among the 1 in 100 heart births which we are getting, approximately 1.5 per 1,000 live births are those congenital heart diseases which are called as severe congenital heart diseases. By severe, I mean that they need the intervention in the first month of life. By intervention, I mean either it is a surgical intervention or it can be a percutaneous cath lab intervention. But the intervention is needed in the first month of life, in the neonatal period also. So approximately 1.5 per 1,000 live births of these babies will need that. If we talk about the risk factors, like many parents who are having children with congenital heart disease, they will always ask us the questions, what are the associated risk factors of having a baby with congenital heart disease? So frankly speaking, in up to 85% of the cases, they are spontaneous and there is no congenital heart etiology known for that. Some of them are heritable, genetic causes have been ascribed. Some of them can now, like chromosomal anomalies, maternal rubella has been implicated in some of the congenital heart disease, maternal diabetes, family history of congenital heart disease, like if someone in the family, especially the father or the mother is having a congenital heart disease or a sibling, the chances of a sibling having the congenital heart disease will be around 2 to 3%. Exposure to teratogenic drugs in the first trimester, as it can cause teratogenicity of any other organs developing, it can affect the heart also. And it has been seen that in vitro fertilization pregnancy, they also have a high risk of congenital heart diseases. One important factor which has to be ascribed is this, that freely available over-the-counter drugs which are available in our pharmacies in our country, this leads to antibiotic and other drug abuse because they're easily available. Anyone can go to a chemist's shop and ask and demand for a medicine of headache or cough, cold, anything. And this abuse can lead to, in the first trimester of pregnancy, these abuse can lead to its teratogenic effect. Increasing paternal age, like, or increased paternal age, like we all are aware of the Down syndrome, which the incidence of which increases at a much higher pace beyond 35 years of age. So this also has a factor, and Down syndrome itself will have congenital heart disease in the form of AV canal defects. Increased maternal BMI have been seen to have congenital heart disease. Parental consanguinity can lead to autosomal recessive diseases, and in which CHD has an incidence also. I would like you all to see, like, this is the scenario in our country, which is like very much important to be understood. In the graph which is on the left side, it is shown that most of the babies which are born in the with congenital heart disease are confined to the northern part, approximately 84,000 of it, and because it's like the larger area it covers, and around 12,500 babies are born in the northeastern parts. But if you see the graph on the right side, it depicts something which is like quite alarming. If you see the third bar graph, it shows the incidence of distribution of congenital heart disease which have access to like treatment in the form of surgery. Like total number of 6,000, approximately 6,000 kids are born with congenital heart disease who require an intervention in the first month of life, and out of them 72% of them are able to get the access in southern part of our country, whereas if you look into the eastern, central and the northeastern parts, it is less than approximately 10% of them are able to access this service. So this is like a quite contrast which is there in different parts of our country only. If you see the northeast, it is practically inaccessible to even a single patient who is there. And this is the latest data which we have. It's of 2020 basically. And I don't think as of now, I don't know any pediatric cardiologist who is dedicatedly there among my colleagues who is there in northeastern part of our country. So the scenario is quite alarming if you see this graph, and we have to be aware of this thing. Basically, moving into the data, struggling with this, like one thing which has to be incorporated and understood is that congenital heart diseases are treatable. This is the most common thing. And the children who are having congenital heart disease and they have been treated, approximately 70 to 80% of them will not need any further treatment in the future life. Only up to 20% of them will need repeated surgery, second surgery or a third surgery, or their lifespan might be a bit lesser than those of the normal population. So 80% of the patients who have a congenital heart disease and have been treated for it, they won't need any further intervention for it, and they will lead a normal life. This is an important thing. Looking of the data will always be alarming. Our doctor-patient ratios, our cardiologist ratio, cardiac surgeon ratios are of course very much less than the western part of our country. So as I was telling that approximately 2.5 lakh children are born per year in our country with congenital heart diseases, and approximately 1/3, 25 to 30% of them will need early intervention to survive. To our alarm, it should be known that only there are 62 centers in our country who are dealing with congenital heart disease management, and only 9 of them presently in our country are those centers which deal with more than 500 surgeries per year. And these have been called as high volume centers. And you can count them on your fingers. These are such less in numbers, basically. So we need to go ahead a long way to have like even 2.5 lakh children. We are unable to be fair to them and give the treatment which they need, basically. And the centers which I was just talking about, the 9 centers which are high volume centers, they are also mostly confined to the private sector, which is mostly unaffordable to our masses. Resources are always inadequate, and if they are adequate, they are mal distributed. That is the thing in every part of our country. Southern centers, there are more centers clustered of treatment for congenital heart disease. They are mostly centered in certain parts of our country. These southern states are economically better than the other parts of the country. They have a better literacy. We all are aware of Kerala model. And the eastern and the central parts practically have no access to the affordable treatment. We just had a look on the graph. And of course, our problems will be endless. That is like anyone who has a problem, the list of the problems will be there. There's a rapid population growth, lack of healthcare funding by the government. There are competing priorities, whether to give importance to these kids who have been born with a defect is a thinking which is there, or we should invest in something in those children who are not having any defect. So again, I'll repeat that those children who are born with congenital heart disease, 80% of them, when they get their first treatment in the form of surgery or intervention, they won't need repeated interventions after that, and they will lead a normal life. So we have to look into this aspect on these children also. And of course, these care of congenital heart disease, post-operative care and all, they will need a trained set of staff, and we really have a deficit of this. Antenatal detection of congenital heart diseases in the form of fetal like TIFA scans and fetal echoes. We all know that how many of our patients get their TIFA scans and fetal echoes. So it's very low in our country. Whereas if you move to the UK, their data says that around 95% of them, they will have their congenital heart disease detected before a kid is born. So it's very less, in the tune of approximately 10 to 15% in our country as of now. And many insurance companies, I should not say many, but rather all of the insurance companies do not cover these congenital heart disease treatment just after birth. And 35% of these cardiac surgeries are funded by families themselves, and the cost of which may be more than the annual income of the family. This is irony. Government schemes cover, like schemes are there. There is Arobishri scheme running in our state. There are different schemes, but the government schemes which are given, they cover only just 30 to 40% of the actual cost which is incurred in the treatment, which includes surgery, salaries of the staff, the special ICU equipments and all. These are like something really which needs a lot of money in that. And the schemes which the government runs, they will give the hospitals the amount which is approximately 40 to 50% of it. So running these in a long term and sustaining this really becomes difficult for the hospitals even. And of course, charitable organizations are always there. They will be there, but they of course will have a long waiting list in that. There are always religious, socio-cultural practices which are prevalent in different parts of our countries. There is a habit of seeking medical help at an advanced age. Like if we have been told that there is a problem, we will see that if the child is growing well, if the child doesn't have any symptoms, we won't get the treatment. We will get the treatment at an advanced age. That's just a common mentality which we have. It is nothing to blame, but this is the mentality in which we all have been growing, when we are a part of it. Gender bias is always there, especially in some of the northern states of our country. There is also a fear that congenital heart disease surgeries will have a chest scar, and there will be a problem while marrying these girls later on. This is like a scare which is prevalent very much in our community. Of course, government doesn't invest much of the GDP in the healthcare sector. We all know that. So what can we do to prevent this? As we know that we are not aware of the causes. Basically, 80% of them, we are not aware of the causes. So it's really difficult to prevent them. Reduction of fertility rate has been tried in some of the Western countries, but it hasn't given them much good results. Women empowerment and education, of course, will always be a part of it, because this will lead to improved efforts for family planning also. And if the women are like educated, literate, they will have more of social awareness. They will seek the healthcare facilities early for their children. And Yuva Nari is one of those organizations which is helping a lot in creating awareness in this. And I'm really impressed by their vision, which is like in the next 10 years, they will be moving ahead to give their countrywide coverage. This is really a very good vision which they have, and they are working for it. Parental counseling to avoid the known risk factors, which are like avoidable risk factors like smoking, alcoholism. Those risk factors can be controlling the diabetes mellitus. Those things can be reduced to a reasonable extent. Immunization against rubella, as we have seen that congenital rubella syndrome is something in which congenital heart disease is a part of it. So if rubella is a preventive disease, if all the children and the females are immunized before they are in the childbearing age, this will decrease the incidence of congenital rubella syndrome, which will of course decrease the incidence of CHD also. Folic acid fortification, the normal knowledge which we have, like folic acid decreases during the pregnancy first trimester. If folic acid is given, it decreases the neural tube defects. But now if we have multiple studies which are seeing also shown that the incidence of congenital heart disease also decreases if the folic acid is not deficient in those pregnant females. And the Western countries like US and Canada have already started fortification of their flour with folic acid. Of course, diabetes, hypertension needs to be controlled at the time of pregnancy. Cessation of smoking, avoiding passive smoking, alcoholic intake has to be decreased, of course. Harmful over-the-counter available medications have to be like, there should be some ban, which is prevalent in some parts of our country, but it is, I know, even if it is a ban, it is easily available at any parts of our country. And vitamin, iron, calcium supplements in appropriate dosage should be given to all of these pregnant females. Genetic counseling is especially important in those situations if the parents have a congenital heart disease, or a previous child is having a congenital heart disease, or any relative with congenital heart disease. If first degree relative is there with a congenital heart disease, that there is approximately 2 to 3% of having a congenital heart disease. And this also depends on the type of the lesion which the child has. Like if someone has a lesion in the left side of the heart, the chances of recurrence are much higher than those who are having a lesion on the right side of the heart. So it is like disease specific also, and it depends on the degree of relationship also. Fetal echo, frankly, should not be considered as a tool to prevent the CHD, but of course, it is an important tool in which we can know about the congenital heart disease to much extent, and we can further plan about how to go about after delivery of these children. Like some of the critical congenital heart diseases are there. If we are aware of those, the delivery of those patients should ideally be done at a center which is back up with a cardiac center, so that a pediatric cardiologist is available and the screening of that child can be done immediately without any waste, and the transportation and all can be minimized. And it is usually done in the weeks of 18 to 24 weeks. And of course, should ideally be done before 20 weeks because MTP is illegal before 20 weeks. But it should not be considered as a tool to prevent congenital heart disease. These are some of the like rare causes, like harmful effects of certain organic solvents, which are used in dry cleaning, nail polish removers, and avoidance of contact with persons with symptoms of viral infections, because viral infections can lead to teratogenic effects in the first trimester of pregnancy. So talking about the strategies for improvement in the slide, like we have limited resources which needs to be optimally utilized. Health is a sub-state subject which differ vastly in economy. The states, they are very much widely varied in their economic status, literacy levels, population, density of population. There are different cultural beliefs, language barriers, human development indices are different. And one size fits all approach is not tenable. We have to specifically think of congenital heart diseases. We cannot think along with the adult heart diseases. We cannot think of congenital heart diseases. We cannot think with other pediatric cares with congenital heart disease. We have to have an approach in which we are especially taking care of those kids which are having a congenital heart disease, because these kids really are a bit different, but they can be treated well. Mass immunization against rubella and folic acid fortification needs to be done, and comprehensive program which caters to the well-being of all children can be taken into account. Periodic education to sensitize the practicing physicians and pediatricians is very much needed, has to be updated. Everyone needs to be updated in this field, and people have to be made aware of the availability of advanced CHD care in our country, because many of them are not available. That many a times I have seen like fetal echoes, which are just having a echogenic foci and they have been sent for termination and all. These are like fetal echogenic foci is like something which is not at all of any importance if it is single, and there is no relation with congenital heart diseases in those. Small VSDs are known to regress with time, even in the intrauterine life. Small, even if the VSD or the ASD or a PDA, something like is there, it's very minuscule and it can be treated even without surgery with interventions like we do it in cath lab. One important thing which I really need to highlight is there screening the neonates before discharge with pulse oximeter. Like it has been a protocol now that before discharging every neonate from the hospital, a pulse oximetric test is to be done. And if the saturation is less than 94%, we should again check it in another limb. And still, if the saturation is less than 94%, we should screen that child for congenital heart disease, and that too cyanotic congenital heart disease. Not all congenital heart diseases can be caught, but at least cyanotic congenital heart diseases can be easily screened with this, which will rule out our major serious conditions which need first month of life. Establishing more centers and a motivated team which should be supported with the government. And one more important aspect is piggybacking the pediatric cardiac programs with adult cardiac programs. That is important. Like already running adult cardiac programs are there, cath labs are there. So setting up a pediatric cath lab and all, it will be feasible economically. So we can always piggyback with those adult cardiac centers which are already running, and we can add our programs with that. This is just an eye-opener that there are presently only 130 pediatric cardiologists which are really available in our country, and only 110 pediatric cardiac surgeons, and that too are non-dedicated. What I mean by non-dedicated cardiac surgeons is that 110 surgeons are there who will operate on kids, but they will also operate on adults also. So dedicated pediatric cardiac surgeons are those surgeons which are only operating on kids, and that number will, I think we confine to just 30 or 40 in my knowledge. And we all know them by their names, basically. It's such a small number. Pediatric cardiac care is really more demanding than the normal pediatric care. And we really need to have a structural training programs are needed. Now the structural training programs like DM, DNBs have been started. Staff are being trained for that, is like something which has been started, but it has to be taken in more numbers. Telemedicine and internet always have helped us in percolating the knowledge to every aspect of our country around the globe. So I will really like to conclude my talk with these words, like care in our country is really lacking. And it's really a challenge as of now. We are lagging far behind than the Western countries in managing our kids with CHD. The number is really huge and we have limited resources. Many of them, the kids are undiagnosed and untreated. Prevention always have been better than cure, but since 80% of the cases we don't know the cause, we cannot prevent it. This is the irony. And what we know is like we can prevent the congenital rubella syndrome and congenital heart disease along with it. Supplementation of iron during pregnancy, and of course counseling, education of the parents will always help. So education always have its importance, and we really need to go a long way in this. Thank you. We should do something like to create this awareness, and we should help parents reach to those caretakers who can guide us, and because most of them are really treatable, and really they will have a normal life as we have a normal life in the adulthood also. They don't have a limited lifespan. 80% of them won't require a repeated intervention. This is like the thing which I have been repeated again and again so that it percolates into the minds of everyone. That's it. Thank you. Thanks a lot, everyone, for the patience listening. And any questions, they are most welcome.
Yes, sir. Thank you so much. It was very informative and very helpful lecture. Actually, I have few questions. Actually, I'm very feeling blessed to have you here because I have few questions from my practice. Actually, hope it may help me from you. I can take help from you because the time I have come here and practicing since 1 year here in Guntur. So I have faced a few variety of situations where I have to suggest people to terminate or not to terminate.
Right. Very
in few situations, one lady came with to offer scanning reports, anomaly scans with means absence of nasal bone, and also she had arrhythmia, means like tachycardia in the fetus, like 200, 220 it was. Repeatedly it was like that. So her gynecologist, both of them very senior most, so they have suggested her to abort. So she has come with a query like for the second opinion, so that she may go for abortion. She has come almost for abortion. But what I thought is to take one suggestion from the fetal medicine. Right. Then I got to know I got to know few tests we can do on the mother, like ANA profile, APLA test and all. She tend to have APLA positive. Okay. So she had tachycardia. So what I have come to know from the fetal medicine. So she told me prognosis will be good, no need to abort, like that. So right. So in these cases, how we can know to go for abortion?
Yeah, of course. This is a very important question which you have asked, and I really thank you for asking this question. Like many of our colleagues who have been practicing obstetrics are facing the similar problem, that many a times the fetal like the TIFA scan is showing an abnormality like fetal arrhythmia, all fetal bradycardia is there, or some structural heart disease is there. There is a VSD or some like TGA, TOF are there, which are being seen. So first of all, like it's the first thing which I would say in medical practice is like for ourselves, we should always discuss our cases. This is the thing which opens multiple brains. Something I'm not doing what you are doing. You are a specialist in certain aspect. I'm practicing certain aspect. So if something comes like this, it's like interdisciplinary. We should all sit down and discuss on the case on these basis, case to case basis. Of course, first of all, like if something like related to heart comes, it's very good that you have consulted a fetal medicine specialist, and those are the best person to be first approached to. That's very good. Concerning to heart, if it is there like fetal arrhythmias, are there bradyarrhythmias, tachyarrhythmias, we actually do fetal scans for them and see what type of actually arrhythmia is there. Some of them can be sinus tachycardias also, or some of them that there can be blocks and all. So many of these fetal arrhythmias, we are able to treat them with maternal drugs, like maternal oral drugs like digoxin, sotalol, flecainide, which are like not very safe, I should say, but they are quite safe because we have been using them in our practice. And these are the drugs which the mother has to take by oral injection also, and IV is also available. Initial like digoxin and all, we digitalize them with high doses so that the heart rate is controlled. And further, if the heart rate is controlled, the chances of high drops and fetus getting aborted and all decreases. Many a times we have followed up these patients, like we have given like 2 to 3 months, even medicines have been continued in pregnancy, and we have seen good response. It's not that it's always a good response, but each case has to be seen case wise. Many of our patients have been treated with oral antiarrhythmics, and even in the postnatal life, we have seen the kids to be having a normal sinus rhythm with normal, structurally normal heart. So if the heart rate is not like so lethal that it is causing high drops and all, it should not ideally be like suggested for termination. And we should always like discuss these cases among like our colleagues who are maybe more seeing these cases, so that our final consensus which can come for that patient comes out to be the best. So I will suggest every one of our colleagues who are there, who are hearing and not hearing anyone, that we should always discuss the cases, all our cases, because it's not that we can give every decision from our own side, because we are not experts in that field. So we should have a habit of discussing the cases and give the best to our patient, which is there. Because termination is not a solution, because it's hard. It's like just a word for us to tell them for termination, because it's really a thing which we really have a psychological impacts also. And if it is a treatable condition, it should not be terminated, of course.
Yes, of course, they were so happy, and I delivered a beautiful
Yeah,
girl child, and she's very happy, healthy now.
quite appreciable. Very good.
Yeah, I was so happy to take that opinion. They have guided us for the tissue Dopplers at the pediatric cardiologist, but the couple was not that much affordable, and patient was suffering from COVID also at the same time. So she was not that much active to go here. Means Vijayawada, they were sending to Vijayawada for further means investigations. But they were reluctant. But after my this opinion, they were sure that they are going to give birth. They are not going to abort. So I was happy. And another case I have seen, sir, she came to me with a severe BP, like she had hypertension. Means she was having in 3 trimesters, she was not having that much blood pressure, but at that time she had impending eclampsia she had, sir. When she came to my OPD, she got fit. Then immediately I have managed her with Maxself, and that all was okay. And next day I have taken her for Doppler study, and I delivered baby. And after that, so after 1 month or so, means when she came to me for checkups, and her baby was diagnosed with the ventricular septal defect.
Okay. So very good. So like it's good that you have managed that eclampsia patient who was throwing fits, and you managed her well. That's very good. And the importance of baby, like ventricular septal defect is the most common congenital heart defect which we have basically, and these depends on like should we really intervene or not. It also is a question in those cases, because those ventricular septal defects which are small in size, of a few millimeters, we compare them normally with the diameter of the aorta. So I will not go into that detail because it's not of significance. So those ventricular defects which are small in size, they tend to close over time, and they won't create any problem for the child. So we ask them to wait without any medicine basically. Those of them which are really large in size and are leading to feeding difficulties, like they have suck cycles, they have congenital heart failure, they are having repeated like pneumonias and all. So those VSDs needs to be closed. They are very large, and the symptoms, and the child won't be growing. They will be tachypneic, and those symptoms are very much evident in the initial 2 to 3 months of the life. The middle category of VSDs are those which are moderate in size actually, So those VSDs are those which need support in the form of medicines, and they can be seen followed up over time. If the child is growing well, is not symptomatic, and the medicines are able to control those symptoms, then we will ask them to wait till we get any, like if it is not closing and the child really develops some symptoms. So because the VSDs tend to close, especially the muscular ones, they have a high chances of closure. So we'll follow up them. So it's not that any VSD which is coming to us will need some intervention. And there are some VSDs which are like can be closed with device also. By device, we do it in cath lab basically by percutaneous route. We'll do it by, we will go through the femoral vein and artery, and we won't give any scar and all, and we'll close it with devices. So like it really depends on how the child is acting and what is the size of the VSD actually, and what the lung pressures are. If the lung pressures are high, it means that the VSD is large. Then we will have to do something. We'll have to intervene in those cases, basically. So what was there in your child, I don't know. Maybe when we'll see it again, we can follow it up in your child. The size of
they had 9 mm of defect something.
Okay, 9. It seems to be moderate to large only. So it needs medications initially, and maybe it will need surgical intervention.
Okay, sir. So, sir, can you give your opinion about anti-scan, dual marker, anomaly scan, and fetal Doppler? Among these, which could be a very sensitive thing in the initial case to look for the congenital heart disease.
Yeah, just like you have antenatal scans like triple markers, quadruple markers and all. They will give you the aspects of like if the child is suspected to have like trisomy 21 and all, Down syndrome and all. And it is seen that those kids who are having Down syndrome, 50% of them will have a congenital heart defect. And out of them, they have a specific type of congenital heart defect, which is called as AV canal defect. So 50% of the babies with Down syndrome will have a congenital heart defect. That is for sure. So in these cases, these scans are normally done in, I think, second trimester in this part. And with regards to the fetal echo, we normally do it around 18 to 24 weeks. This is the ideal time. Even early fetal echo also some people are doing. But it is really very difficult to see the different parts of the heart, because the heart will be of very small size of a peanut at that time. To see the details, final details will be very difficult. So during the 18 to 24 weeks time, we can actually see the structure of the heart, actually how the heart is beating, the rhythm of the heart, different structures, how the great vessels are there, how is the aorta, PA, are they crossing, not, what is the size of the different chambers. This will give us the clue actually, like where. And one more thing, important thing which I would like to emphasize here in this part is there, some of the conditions tends to progress over time in the repeated fetal echoes, and some of the conditions tends to decrease with time in the repeated fetal echo. So we should not give a judgment in the initial one only fetal echo. Like if I diagnose a VSD today in 18-week scan, and if I see it after 6 weeks, it might have closed also, because they are known to close even spontaneously in the intrauterine life also. So, and some of the conditions like valvular stenosis, some valvular stenosis is there. It tends to progress with gestation. So if we do a repeat scan of that after 6 weeks or 8 weeks, we might see that initially it was just like a mild stenosis. Now it has developed to a severe stenosis, which is leading to chamber size decrease also. This is also a condition. So it needs to be repeated also. One fetal echo should not be like the one which is guiding everything. I think Dr. Sharma's connection is gone. Any other question from anyone? Yeah.
Hi, Muta sir. This is Dr. Someshwar here.
Yeah, Dr. Someshwar. Carry on.
Yeah. Sir, I have a question. Is there any national program to see prenatal screening for the congenital heart defects?
National program to see for congenital heart disease. If you ask for me for the prenatal diagnosis, you are asking of a prenatal diagnosis. We don't have a national program to diagnose it postnatally also for diagnosis. Like it is not recommended as of now to screen every baby who is born for the congenital heart diseases. Okay, maybe I'm not clear. I'll tell you, like even it's like in many of hospitals now they are doing like to rule out congenital heart diseases, they are ruling out in every baby they are doing echoes, mostly in the private sector, to see if any congenital heart disease is there, and that should not be missed out and can be taken care of initially. So it is not a routine or not a guidelines in our country as of now to even screen them postnatally. And of course, antenatally, there is no program at all to guide them. Of course, people like second trimester scan, which is like the TFA scan, guides a lot in knowing the structures, different structures at that time. And if there is any suspicion while doing the TFA scan, they refer to us for specific fetal echoes, which we do. In fetal echoes, we will only screen basically the heart and see the heart functioning, the heart rhythm, how the chambers are, how the different vessels are which are coming out of it. Are they crossing normally or not? What is their normal positions? What is their normal size? Which varies, of course, with the gestation. So we have to see them precisely and then give a final opinion, because it's not only the diagnosis. We have also to give the opinion to the parents what will be the future course of this congenital heart disease. Many of them will ask a direct question: should we go ahead with pregnancy or not? This is the first question. Second question is there: if we go ahead with this condition, what will happen to, like, how many surgeries will be needed? When will the first surgery will be done? Even what will the cost of the surgeries which you are talking about? Or how will the life going to be? How is the life going to be after having those surgeries and interventions? So these are some of the things which we have to deal about. It's like, along with the diagnosis, you have to counsel them also in the fetal echoes, basically. Yeah. So that's why I want everyone to be on the same platform. Like, we should be in coordination with the fetal medicine specialists. We should be in coordination with the obstetricians, treating obstetrician. We all should be on the same platform so that the patient gets the same view. It's not that I'm talking something and I don't have a link with my obstetrician, and the patient goes to the obstetrician, she talks in some other direction, I'm talking in some other direction. So we should have a common discussion, and the patient should be given something which is like they can really, it's best for them, basically, and easy to grasp also for them.
Yeah, yes. So
thank you, sir.
So actually another scenarios like torch means toxoplasmosis, like that, rubella. In these infections, what will be the prognosis? Means is there any chance of really intervention, or we can wait and watch?
Yeah, in the case of torch infections, I'll confine myself to congenital heart diseases. Normally, what we get in those cases is pulmonary stenosis. In those cases, then a PDA can be there. So PDA is like patent ductus arteriosus, which is a connection which is normally present in the intrauterine life, and that should ideally close within 3 weeks, within 1 week of life, ideally. So even if it is like open, in those cases, it can be easily closed with a device later in life, after 3 to 6 months. That can be closed. That's not a much of a big deal. And even if valvular PS, which is known to affect in the case of these cases, in the torch infections, it can be balloon dilated. We can dilute them percutaneously. No surgery is needed. They might not respond in that proper fashion. The results might not be very good, like full stenosis might not be overcome. But of course, reasonable extent of stenosis can be taken care of. Like, stenosis will decrease a lot. So basically, pulmonary stenosis and patent ductus arteriosus are seen in these cases. Of course, they can have other things also, but these are the most common things which we see in our practice.
Okay. One last question, sir. Actually, in one of my patients, she delivered this time after IVF in another hospital. She had IVF, and here she delivered a healthy child. But as I was very much curious why she had 6 abortions, and in her last abortion, that means in the 6th month she had abortion with the IVF only, but she had APLA positive, and also she had a very big subchorionic hematoma that time, and fetus had cardiomyopathy. Is this cardiomyopathy prognosis is not good, or what? Please throw some light, sir.
Yeah, basically by cardiomyopathy, the function of the ventricular function and all would have decreased, of course. So we would like to see like what the rhythm and all of there is of the baby. And if hydrops is there, of course, it will have a decreased prognosis. So if the functioning is not very much decreased, ventricular functioning is not very much decreased, and hydrops have not developed, so they will have more chances of having like better outcome. It's like that way. It's not that just one, like if we have a diagnosis of cardiomyopathy, it will be bad only. 1/3 of them will regress itself also, 1/3 will remain the same, and 1/3 might deteriorate also. So those who deteriorate, normally they will develop hydrops and all over time. So those will be something like bad prognostic markers for them, basically.
Thank you. Thank you so much, sir. So it was very informative and very useful session, sir. So I would like to express my gratitude to all the delegates of the webinar for their presence, and I extend my heartfelt thanks to our distinguished speaker for giving excellent lecture and recognizing our questions and queries and solving them. And I would, last but not the least, I would like to thank our technical support, Shield Healthcare. Thank you so much. So
Thank you.
any
Thank you,
more, any
everyone.
questions?
Any more questions? I think everyone is tired now. We can close the session. Any queries can be emailed to me anytime. That is like my email will be Murtaza, MURTAZA, my name, which is written here, Murtaza .VMMC @gmail.com.
Yes, sure. And any queries from, if we get through means YouTube or NARI'S Healthcare Facebook, we will come up to you, sir, surely. Thank you so much, sir.
Okay, thank you. Thank you all. Good
Thank
luck.
you.
Bye.
Bye. Thank you, sir.
Thank you, sir, and thank you, Shama Sultan.
Yeah, thank you.
Many thanks
Yeah.
from the Shield team to all the delegates.
Thank you. Bye.
Bye.